All right. Good evening, everyone, and welcome to this webinar this evening where we'll be speaking a little bit about obesity and some of the options available to those who want to lose weight and live a healthier lifestyle overall. I'm Dr. Alfred Dawes. I'm a general laparoscopic and bariatric surgeon, and I practice out of the Windsor Wellness Center. I'm also medical director for Caribbean Medical Limited. And just a little bit of background. I'm a former associate lecturer at the University of the West Indies Medical School, for the Faculty of Medical Sciences and Department of Surgery. And I'm also a former senior medical officer of the Salomar Public General Hospital. Now, today I'm really in my capacity as one of the local experts in obesity, and I'd like to share a little bit about my experience and, in fact, the worldwide experience in treating obesity. And so I ask you to just stay tuned, hold your questions for the end of the presentation. I know there's going to be a lot, and I just want to get through as quickly as possible so I can get around to answering all of these questions that I know you must have for me. So we can begin now. All right, so the topic of today's webinar is obesity, an epidemic that has a solution. Now, just a general overview of what the talk will be about. The obesity problem, we'll go into a little bit more about it, why obesity is actually something that we should be very concerned about. We want to speak a little bit about the metabolic syndrome that is less of an entity in people's minds, but very, very important in terms of our healthcare system. And I want to introduce some of the surgical options and their role in the management of obesity. So let's start with the problem. What exactly is obesity? Obesity and overweight are defined by a BMI, which is a scale that we use. Now, if we are talking about somebody's weight, if I hear that there's a 220-pound patient outside my office, that means nothing to me, because if that patient is 6 feet 5 inches, it's completely different than if they're 5 feet 1 inch. And so we developed a scale to determine if somebody is an appropriate weight for their height. And we call this scale the BMI scale, or the body mass index. And it allows you to get one number, and automatically you can deduce whether somebody is underweight, an appropriate weight, or they're overweight or obese, depending on what that number is of their weight in relation to their height. And it's typically calculated by dividing the weight in kilograms by the square of the height in meters. So that's a simple mathematical formula. And what that allows us to do is to tell exactly whether somebody is considered weight appropriate. So you're considered overweight if your BMI is between 25 and 29.9. Normal BMI being anywhere from 19 to 24.9. A BMI of 30 puts you into the obese category. And we can go up if your BMI is greater than 40, then that is classed as a stage 3 obesity, or it's known as morbid obesity. So just a little bit of what it's like. So if you're underweight, under 19, you're really underweight. The 19 to 24.9 is what we consider to be a normal weight. And there are some variations, of course, by race. So if you are Asian, we're expected to have a smaller frame. At 24, you would be considered to be overweight, whereas for the African diaspora, who tend to have a higher frame, a stronger build, then you would not try to get down to a BMI of 24 to be considered normal. You would accept 25 or thereabouts. But universally, once you start to get into the 30s, that means that you're obese, and there are significant risks that come with having obesity. Now, we hear about this obesity epidemic, and we hear that it's growing right around the world. Every 10 years, there's a significant, it's increasing by about 1 percentage point per year. And right now we have an obesity rate of overweight and obesity rate of over 50%. Of this number, women tend to be more in the overweight and obese category at about 33% being overweight, being obese, whereas men, it's a little bit lower, it's at about 25%. But we tend to think of it as just persons eating too much and not exercising enough. That's the stigma, after all, where you say that, you know, they are overweight and they're obese because they eat too much, or they're just lazy. And that's part of the whole fat shaming issue that we must address if we are going to really tackle obesity. So is it really about too much food and too little exercise? Is that the real cause of the problem nowadays? And there have been numerous studies that have showed that the obesity epidemic that we are experiencing is not due to just eating too much and not having exercise at the appropriate level. And there have been a lot of research, a lot of programs with some of the best investigators in the world, and they've found no effect to just tackling exercise and food as the primary endpoints of obesity. The truth is that we live in this modern world, what we would term an obesogenic environment, meaning that our world is designed to make us overweight and obese. And there are so many developments that have made our lives more comfortable, but with those developments, they also make it more easier for us to get overweight and obese. For one, we don't get enough sleep. On average, the number of hours that we used to sleep has fallen significantly from generation to generation. And we do know that there is a direct correlation between restful sleep and the levels of steroids known as cortisol in our bodies. Cortisol naturally falls during periods of restful sleep. And cortisol is one of the hormones that actually causes us to gain weight. So persons who have sleep apnea and they're not getting restful sleep, they tend to put on weight a lot easier, which in turn worsens their sleep apnea, leading to a vicious cycle. But overall, if we're not getting enough sleep, or we are glued to our electronic devices, and so it disturbs our sleep pattern, then you are actually putting yourself at increased risk for developing obesity. Now, in the olden days, and this applies less to the Caribbean, but some of our more temperate neighbors, when you're cold, you tend to shiver, and shivering burns energy. Now we have central heating, so there's less need to try and keep warm, less shivering, and that incrementally can cause some amount of decreased energy expenditure, which means that our metabolic demands or caloric demands are less than what we will be taking in. Believe it or not, smoking is one of the deterrents for eating, or on the flip side, whenever you quit smoking, you tend to eat more. And where nicotine, we know, actually suppresses our appetite. And with the war against smoking, we are actually seeing one of the effects being that it may be contributing to obesity. Not saying that we should start smoking to lose weight. Please do not quote me on that. And the truth is that once you are an overweight mother, you tend to have overweight children, whether this is due to just a genetic predisposition, but it may be, or the habits that one may have in the household. What we do notice is that once you're overweight, your children tend to be overweight. It could be the eating habits, or it could be just simply a genetic component why children who are born in households where there is a higher level of weight, obesity, they tend to put on more weight than their peers. And this is another fact, overweight mothers tend to have more children. I'm not sure why, but the stats don't lie. Older mothers as well tend to have overweight children. And we do see where mothers are giving birth at a later age because of deferral of having children, childbearing, because of professional commitments. And in general, once you get older, you tend to put on more weight. It is a natural progression where we lose muscle mass. And once we lose muscle mass, we have less resting energy expenditure, meaning that our basal metabolic rates fall and it's easier for us to put on weight eating the same thing. Drugs, in fact, can make us put on weight. Insulin that is used in the treatment of diabetes, it is actually a type of hormone that causes us to put on weight. So it helps to worsen the condition that it's actually treating. And of course, there's also the environmental pollution, and we think that there may be some element of hormonal interference in this modern world. And there's a question of whether persons who are overweight tend to form relationships leading to genetic predispositions or creating households that may not necessarily have the best eating habits for their children. So are we really in an obesity epidemic? We do know that obesity has been rising the world over. And in fact, the Centers for Disease Control and Prevention, the CDC, they state that obesity is a national epidemic. This is in the US, and it is not just a weight problem. It can have serious negative effects on a person's overall health. So it's not just to say that you're carrying more weight. A lot of patients who come for weight loss, they just want to look better. But the fact of the matter is that we have to accept that there are increased medical risks to carrying around excess weight. And that is what we have to look at. There's a fine line between fat shaming and advising persons of the need to lead healthier lifestyles. And that is where we have to strike the balance in trying to combat this epidemic. So one of the reasons why we have an issue with obesity affecting persons' health is that obesity is linked to the metabolic syndrome. What exactly is a metabolic syndrome? Well, it's a combination of obesity, and you may have other issues such as high cholesterol and glucose intolerance. Glucose intolerance simply meaning that you can't regulate your blood sugar levels, and that is the first step towards developing full-blown diabetes. So together, all of these issues, you may have hypertension as a part of this syndrome as well. All of these lead to an increased risk of morbidity, meaning you're more likely to have worse outcomes for simpler operations, more disastrous outcomes in trauma, and you're more likely to develop complications of chronic diseases, leading to an increase in death. So one example is diabetes, and this shows you exactly how interrelated these chronic diseases are. Once you're diabetic, you have increased risk of pregnancy complications. You may have nervous system diseases where you may not be able to feel any sensation in your feet. You're more prone to getting accidents. You may actually have a cut on your foot and not realize, and that may lead to infections, that may lead to amputations. Now, by itself, the diabetics tend to develop more atherosclerosis, which is the narrowing of the arteries because of the deposition of plaque. And so the blood flow decreases. Whenever blood flow decreases, it can affect the blood flow to your eyes. That can lead to blindness. It can lead to another form of, another cause of amputations. And of course, with decreased blood flow to the heart itself, you can have chronic heart disease. Decreased blood flow to the kidney can in fact lead to renal failure. So everything is interrelated: the diabetes, the atherosclerosis, and the hypertension. And all of these are precipitated by obesity. So when we look at these chronic non-communicable diseases, we find out that there are it's not just a simple thing where you eat too much salt and so you're going to get hypertensive, or you eat too much sugar and rice so you're going to get diabetic. It's multifactorial. The truth is that there are underlying socioeconomic and cultural reasons why persons eat a particular way, the foods that they have available to them, the quality of the foods they have, and globalization, urbanization, and the overall aging of the population as one of the benefits of improved public health all lead to changes in who is alive and what they get to eat. So overall, that can lead to an unhealthy diet, especially if you can't afford to eat healthy. Physical inactivity because of more sedentary lifestyles with the creature comforts. We no longer walk wherever we're going. Sometimes we don't even walk to the bus stop. We can get food delivered whenever we want. So we spend our times in vehicles getting to and from work, sitting at a desk, rather than being out in the field doing manual labor. Tobacco use is still prevalent, even though it has decreased in recent years. And of course, some of the factors that we can't get rid of are age and our genes. Sometimes it's just what we get passed on from our parents, and it's not like we can choose better parents. So we're stuck with the genes that we have. Now, there are other risk factors. So these factors can lead to developing some of these chronic diseases. And so we end up with raised blood pressure, hypertension, raised blood glucose, which might be pre-diabetes and later on diabetes. And of course, abnormal cholesterol. And when we have obesity in that mix, then we start to develop complications. And this is when we start to get heart disease, strokes, cancers, chronic respiratory diseases, and of course, diabetes by itself can cause death, or it can lead to, as we saw before, chronic kidney disease and other issues that can lead to an untimely death. So everything is linked, and one of the biggest risk factors for developing all of these chronic diseases and worsening outcomes in these chronic diseases is excess weight. So it is not just to say that you are overweight or you're carrying a little bit more weight. You are actually in a position where you are more likely to be sick. You're more likely to have worse outcomes in trauma, surgery, and complications from these diseases, and unfortunately, more likely to die at an earlier age. And we tend to think of these as diseases of affluent countries, but the truth is that with the changes, the socioeconomic changes that I had mentioned, 80% of chronic disease deaths occur in low and middle income countries. And a lot of that is related to the lack of access to healthcare. So what is going to lead to death in these patients are heart attacks. And if you don't have the percutaneous angiography, the stents, and all of these clot-busting medications available within minutes to hours of presentation at a hospital, they're more likely to die from a heart attack. Same goes for stroke as well. And because poorer countries may not have developed health systems, whereas in the more affluent societies, even though they may have these issues, they're not going to die as quickly from a heart attack as somebody in a developing country, because we do not have the resources to treat these complications of these chronic diseases. So we have been trying to battle this obesity epidemic. We have been trying to battle the chronic disease epidemic that is a result of obesity, and we have not been doing very well. Every year it's getting worse, and we have to ask the question, what is the solution? And this is where we have to look outside of what we've been told about just simply diet and exercise, because we've seen that that is not necessarily the answer all the time once you're obese. So we have to look at bariatric surgery. And this is where I want to spend a little bit of time explaining what are the options available for us to address this epidemic. So bariatric surgery options with a BMI of over 40, or if you have chronic diseases, your BMI between 35 and 40, in order to achieve weight loss that is more likely to be permanent. And I say this because when you compare bariatric surgery with diet and exercise at 10 years out, those who go the simple diet and exercise route, they have a 95% failure rate, whereas it's the opposite for bariatric surgery, simply because it's difficult to stay on a diet over the long term. Bariatric surgery is used to treat or prevent obesity-related comorbidities, example, diabetes, hypertension, heart disease, and obstructive sleep apnea. You can actually cure or improve these conditions with the weight loss that is associated with these bariatric procedures. Now, some of the more common types of bariatric surgery include the Roux-en-Y gastric bypass, the gastric bypass, as we would have heard it called. The sleeve gastrectomy really taken over in terms of popularity over the last 20 years. Lap band, which I'll only mention for historical purposes because it's on its way out due to a high complication rate. And of course, it's under surgical, but it's non-invasive therapy such as the endoscopic intragastric balloon that does not involve going to sleep or doing surgical procedures, staying over in hospital. So we can start with that one. The gastric balloon is literally just a bag or a balloon that is placed in the stomach endoscopically, meaning that it goes through with the aid of a camera into your mouth, down your esophagus or gullet, and into your stomach, where it is then blown up. It's filled with saline or salt water. It stays in the stomach, it occupies some space, and because it's there, it doesn't allow the stomach to contract so well. So it delays the emptying of the stomach. The result being that you are full for longer and you feel fuller. So you're not on a diet all the time, and when your stomach is empty, it's producing more hunger hormones. So you're literally hungry all the time. You have something in your stomach taking up space, the balloon, and the balloon in turn causes food to exit the stomach a lot longer, a lot more delayed than without it. So you feel full for longer while eating less. It's usually removed the same way it was put in. A needle is put into the balloon and it is decompressed and it is pulled out through the mouth. So it's in and out on the same day. It takes about 2 hours from admission to checkout, and the balloon stays in for about 6 to 12 months. I usually go with the 12-month balloon because they have a much better weight loss profile. So I mentioned the Obera 365 balloon. That's if they approve, that's one of the balloons that I'm introducing in Jamaica right now. And it's not just to say that we're putting in a balloon in your stomach and sending you on your merry way. It's a managed weight loss program because you have to relearn how to eat. It's a medically supervised weight loss solution, and nutritionists will guide you through the process. You will have follow-ups with myself, and all of this is geared towards teaching you what are the correct foods to eat, how to avoid developing unhealthy eating habits such as binge eating and starving yourself in cycles. And you can develop healthy habits that will last a lifetime after the balloon is removed. Now, when you look at how much weight you expect to lose, I would say on average, you can lose 40 to 60 pounds. The majority of the weight loss occurs in the first 3 or 4 months, and the rest, it's really to maintain. You may have some amount of weight loss, but what you will end up experiencing is that you may hit a plateau, and it is just learning these new eating habits that you're going to be looking at for the 6 to 8 months after you started to lose weight. Now, the lap band, as I mentioned, it's really fallen out of favor. This used to be one of the most popular bariatric procedures. But nowadays, it's less than 5% of all the procedures done in first world countries. I don't do the lap band. It has a high complication rate because that ring can cause a lot of issues as it compresses the stomach. It can slip up, causing a lot of reflux and blockage of food entering the stomach. It may slip down, meaning that it's not offering the restriction, so you regain the weight and you lose the effectiveness of having that constriction around a section of the stomach, leading to a smaller pouch. So it's really a ring with an inflatable band, and it's placed around the upper part of the stomach, and it's a purely restrictive procedure, meaning that it limits the amount of food you can eat. Whatever you get down, you will absorb it. There's a balloon inside a device filled with a salt solution, and that is placed underneath the skin. And you can adjust it up and down based on how much you want to restrict that area of the. Now, the most popular procedure right now, probably about 80% of the bariatric procedures done, not just in my practice, but I think worldwide now, this is the route that we are going, is the vertical sleeve gastrectomy. And you can see what is done is that the stomach is divided in two with a device called a stapler. And this part of the stomach, what we call the greater curvature, is taken out and discarded or sent off to the lab. And what you're left with is a small stomach that doesn't expand to get food, to accommodate more food. Now, the part that is removed is the part that really expands to accommodate more food. And it's also the part of the stomach that produces hunger hormones. So you're not gonna feel as hungry with that area of the stomach removed. You will still have cravings and you will still feel for certain foods, but that is more head hunger, as we would call it. And that is something that you will have to learn to ignore or manage. So different surgeons use different calibrations to see how much of the stomach they want to leave behind. But on average, more than 85% of the stomach is removed, and you usually end up with a pouch about 3 to 4 ounces. And you have severely restricted intake. To put that in perspective, right after surgery, the first couple of weeks when you transition to a normal diet, you might be able to eat a chicken leg or a chicken wing, and you're full. You try to eat more than that, you're gonna feel sick, and you may end up throwing up. So this is a purely restrictive surgery, and whatever you eat, you will absorb. The downside to it is that if you eat a lot of ice cream, sweets, or you drink beer and other sugary drinks, then you will absorb everything. Compare that to the gastric bypass, that is a restrictive surgery as well as what you term a malabsorptive surgery, meaning that not everything that is consumed is digested or absorbed. And I explain to you why. So the stomach is divided, but instead of cutting out an area of the stomach and discarding it, what happens is that we divide the stomach into two, into a very small pouch. This is usually smaller than with the VSG, usually about 3 ounces. And we take a loop of intestine stomach so that the food has a conduit to escape, and it bypasses the digestive juices that are coming from the other side of the intestine, the pancreas, the stomach itself, the gallbladder. So here where there is no food and no digestion occurs here where there are no digestive juices. So you bypass a section of the intestine, hence the name, so you absorb less in addition to eating less because of the smaller pouch. Now, one variant, and this is a surgery that I do more often than the full bypass itself, is the mini gastric bypass, where instead of cutting and stitching the intestine at 2 different areas, you just simply bring up a loop of the intestine and attach it to the pouch that you created, and you end up with a similar situation where you're bypassing a length of intestines, and so there's no digestion taking place there. and you end up with the restriction and malabsorption as a result. Now, what can you expect post-weight loss surgery? Well, patients typically lose the most weight within 1 to 2 years after the procedure, and then they maintain substantial weight loss with improvements in their comorbidities, such as your diabetes, hypertension, and sleep apnea. You may lose as much as 60% of your excess weight within 6 months after surgery, and it may slow down a bit as you lose more weight to maybe 77% of the excess weight as early as 12 months after surgery. Thereafter, the weight slows right down until you get a plateau, and that is because your body slows your metabolism to the point of matching whatever your small caloric intake is. So you have severe caloric restriction. Sometimes it's less than 1,000 calories per day. And because you're in a caloric deficit, you're burning way more calories than you're consuming, and you tend to lose weight. But as you lose weight, your body becomes lighter. You need less energy to carry it around. Your metabolism slows. You may lose some muscle mass as well that contributes to your metabolic rate. And so eventually your caloric intake matches your energy expenditure, and then you stop losing weight at that point because you have found a new balance. You may have some weight regain because, as I mentioned, your metabolic rate tends to slow. So when you eat high caloric foods, it's easier to put on the weight. Hence why we tell patients that they have to make the lifestyle changes. It's not that you can continue to eat cake, ice cream, and some other foods that we call slider foods, especially sweets and sugar drinks, that can slide right through your pouch or through your sleeve and be absorbed and cause excess calories with your low metabolic rate. Now let's take a little bit of a look on the comorbidities. All of these chronic diseases that we're trying to combat in addition to obesity. Now, surgery or overall weight loss improves our results greater than 40 obesity-related diseases. Yes, that's 40 obesity-related diseases are cured or improved by losing massive amounts of weight. These conditions include type 2 diabetes, heart disease, certain types of cancers, sleep apnea, GERD or gastroesophageal reflux disease. We see that as heartburn commonly, high blood pressure, high cholesterol, and of course, joint problems because you are carrying less weight. There's a 60% reduction in deaths from cancer, with the largest reduction seen in those cancers, namely breast and colon cancer. There's a 56% reduction in mortality from coronary artery disease. You have less heart attacks, and a whopping 92% reduction in mortality from type 2 diabetes. In fact, diabetes has one of the highest cure rates as a result of bariatric surgery, which can be close to 90% of persons coming off medication completely. And you live longer because you have less of these diseases that can cause complications and which may lead to death. You have a 40% overall reduction in the risk of dying if you do surgery and have massive weight loss versus if you try this diet and exercise using fat diets. So really and truly, you get to live long and prosper. There are countless studies that show how metabolic and bariatric surgery increases lifespan. You live longer, and you may, with a gastric bypass, you may improve your life expectancy by 89%. Patients may reduce the risk of premature death by 30 to 40%, and it's one of the best options we have in the fight against obesity and chronic diseases. And of course, your quality of life improves. You can move around a lot faster. Your mobility, agility improves. You have less pain in terms of arthritis. Traveling, some persons would have had to buy 2 seats, but you're able to move around a lot better. And of course, with that comes social benefits. There's an increase a chance of forming new relationships after bariatric surgery. On the flip side, there's also an increased rate of divorce. So I don't know how you would explain that one. But in summary, we do have a problem. We have a rise in the rates of obesity. With the rise in the rates of obesity, it is not just a body image issue. It is a risk factor for developing the metabolic syndrome, chronic diseases, which can in turn lead to complications that can lead to serious morbidity and risks of early death being increased. There are surgical options for obesity and the metabolic syndrome that we should be leaning more towards now, seeing that the conventional approach of telling people to eat right and exercise is simply not working. And with that, we need to look at what is the right option for the patient in the fight against this epidemic. So that's the end of my presentation. I hope that you were able to learn something from it. There were some questions that were sent ahead of time. I don't know if there's anybody who has any questions. No, we could actually go through before I touch on those. So I'll just leave the floor open. Carmen or Thomas.
Yes, doctor. This anyone wants to ask Dr. Dawes can write the question through the chat or in the section of questions and answers. So take advantage that he is here and ask questions. We have other group of questions that you could read in the meantime that someone could ask. Do you have them?
Oh, sure. So one of the trying to pull this. Just trying to. All right. So one of the questions we got from before was, how do I learn to curb my appetite and cravings? And that's a very good question, because as I mentioned, when you are on a diet, you tend to get hungry a lot more often. And there's a reason for this. It's not just in your head. When your stomach is empty, it produces this hormone called ghrelin, and ghrelin causes you to feel hungry. When your stomach is full and stretched, that is when the stomach stops producing ghrelin, so you don't feel as hungry and you know that you need to stop eating. So you tend to have higher levels of hunger hormones when you're eating less, and that's your body's way of saying you need to get in more calories. We tend to call that starvation mode. It's not necessarily true, but our bodies try to balance out whatever we try to do in terms of limiting our intake. And so it actually sabotages our efforts. To do that, you want to keep the stomach stretched without getting too many calories, drinking more water or having more fibrous foods that will stay in your stomach for a longer period of time. And this is why the keto guys do so well, because the fat that they eat stays in the stomach a lot longer. There's delayed gastric emptying, so they feel full for longer. So even though they're eating fat, which is probably has about twice as many calories as proteins or carbs, they still eat a lot less calories. Interestingly, protein doesn't leave the stomach as much as quickly as carbs as well. So protein, having a diet that's high in protein, makes a big difference in terms of how you stay full for longer. So getting more fiber, getting in more protein, and if you're getting in fat, you get in your healthy fats, that may help you to feel fuller for longer. All right, there is One question, good night, doc. I want to know what are the possible side effects after doing these procedures, even if you eat as you should. Thank you. Well, the side effects that most commonly pop up are nutritional deficiencies, and these are usually related to improper dieting. So you don't take your vitamins, you don't take your supplements. And because of that, especially with the gastric bypass, where you don't absorb everything that you eat, you may end up in a situation where you have a vitamin deficiency, anemia, B12, calcium. These are the common culprits. But long term, we are looking at the outside of nutritional deficiencies. You may have reflux with the sleeve in particular, with the gastric bypass, you may have ulcers in your stomach. But again, this is usually due to persons who are drinkers and particularly smokers. Usually you get ulcers, what we call stomal ulcers in persons who smoke. But overall, the side effect profile is low once you stick to your diet. We have another question where Shanice is asking, hi doctor, 4 weeks ago I did a total thyroidectomy. My weight is 212 pounds, my height is 5 feet 3 inches. I am not a heavy eater, but I am considering a gastric bypass as I am classified as being obese. Since I just did surgery, how long do I have to wait? Well, doing a total thyroidectomy renders you hypothyroid unless you take medications. So is it that you are hyperthyroid? Was it for cancer? All of these things would make a difference. But for others who would not know, the thyroid gland, which is found right underneath the chin, on the neck, on the front of the neck, that produces some hormones that regulate your metabolism. If you produce too much, then you're going to end up being hyperthyroid, and you will have nervousness, you will have anxiety, you may have irregular heartbeat, and you will tend to lose weight because your metabolism is sped up. On the flip side, if you have an underactive thyroid, then you don't produce enough of these metabolic accelerating hormones, so your metabolism will be slow. That means that you will store food more efficiently, and that will lead to weight gain. So we need to be in a balance where we're euthyroid, meaning that it's not too high, it's not too low. And once we're at that stage, we can get the surgery done. But you have to be on thyroid supplementation because you don't have a gland to produce these hormones anymore. So you have to take the pills for the rest of your life. If not, you can have serious health consequences. And there's another question. If the patient is having abdominal bloating and having a sensation of fullness all the time and they're obese, which procedure would you recommend? First, we would have to know, why are you having bloating and the sensation of fullness all the time? Is it that the type of foods that you're eating is leading to intestinal gas? Is it that you're not absorbing lactose well and you're having too much dairy? Is it that you're having allergies to wheat or dairy, protein, milk proteins again? It could be that your gut bacteria are off. Some persons don't digest carbs very well, and then it goes through the intestines, the bacteria act on it, and it leads to bloating. These non-specific symptoms can be a symptom of gallstone disease. So you'd have to get checked out to see exactly what is the issue before we can look at the procedure. But it wouldn't determine what procedure is done once there are no contraindications to the sleeve or the bypass or the balloon. One question, is it safe to get pregnant with the balloon? Yes, it is. As a matter of fact, some women would put in the balloon in order to drop 40, 50 pounds so that they may regularize their periods, treat their polycystic ovarian syndrome, and increase their chances of getting pregnant. And we have had some nice success stories where females have gotten pregnant after putting in the balloon or having bariatric surgery done when that was one of their main intents. So yes, it is safe. We just have to determine the timing when you want to remove it. I've actually had one patient who kept the balloon in throughout her entire pregnancy and didn't have any issues. It was removed after delivery. And Shanae's asking, good evening. All my question is regarding PCOS and weight gain. Is surgery the key, or is there another way to fight having PCOS and maintaining a healthy weight? All right, so as I had mentioned, PCOS or polycystic ovarian syndrome is one of the reasons why women may have some difficulty in conceiving. What basically happens is that you have hormonal imbalances that lead to and are related to cysts being formed on the ovaries commonly. You may have irregular periods, and because of this, your hormone levels are all over the place, your sex hormones, your female hormones. But in addition to that, you also have, as a part of the syndrome, insulin resistance, meaning that your body does not respond well to the insulin that it is producing. So you have higher and higher levels of insulin being produced in order to control your blood sugar levels. Insulin, as I had mentioned earlier in the chat, in my presentation, it is a weight gain hormone. So if you have high levels of insulin due to your body not listening to it, i.e. insulin resistance, you are going to put on weight. The weight that you put on worsens insulin resistance, so it's a vicious cycle. So usually when you go to your gynecologist, one, they'll try to regularize your sex hormones, usually by birth control, implants, or other hormonal methods. And they may put you on metformin, which is a medication, a tablet that helps you to decrease insulin resistance. But ultimately, your hormones will not be regularized until you lose some weight if you are overweight with PCOS. But because of your high levels of insulin, it's going to be exceedingly difficult, which is why usually surgical options play a very important role in PCOS. You may not be at the stage where you need bariatric surgery, which is why I love the balloon for PCOS patients. That one was answered. And Catherine is asking, since we're in a pandemic, what is the protocol if I'm coming from overseas? So as part of my protocol for surgeries, if you're coming from overseas, even if you have done the whole negative antigen or PCR test to get into the country, I don't do procedures unless I have a negative antigen test within 24 hours of me operating, because you don't want to contaminate the surgical center, you don't want to infect the staff, and you want to be assured that you're going into a facility that doesn't have anybody with active COVID coming out of it or had contaminated the area. I go with the antigen test because it is a more reliable indicator of somebody with active disease that they can spread, versus the PCR, where you may have cleared the virus or you may have a contamination in your nose, but no full-blown infection, and still test positive sometimes for weeks or months. And Anonymous said, amazing. Thanks, Doc. I'm coming soon. Thank you. Looking forward to seeing you. And Brian is asking, good night, Doc. I'm 6 feet 1 inch and I weigh over 310 pounds. However, with proper diet and exercise, I was able to go down to 212. That's pretty good. 1, I would like to know if I'm still considered overweight. I also suffer from gynecomastia in both breasts and would like to know if this can be cured if I lose more weight. Question 1, there are apps available. Check, and I'm trying to pull one up now to see if you are still overweight, I want to give you your exact BMI. You would probably be in the overweight category, not obese. But as I said, the BMI chart, it varies in terms of races, different races. So what may happen is that you may be, it depends on your ethnicity, you may be in that range. Again, it all depends on where you are, based on your ethnicity. But I this thing up and I'm not getting it, but I think you would probably be at around, based on 6'1", 212 pounds, you might be about a 28 or so BMI, which would still put you in the overweight category. Now, what's important, having lost so much weight, is that you have not lost lean muscle mass, because you can lose fat and muscle once you're losing weight. If you're losing muscle, that means your metabolism is slowing and you want to look at what your fat percentage is like. So the true measure of how healthy you are is not the BMI by itself, but to look at your ratio of lean muscle mass to your body fat percentage. 2, you asked about gynecomastia. Gynecomastia for everybody is what we term breast like a woman, meaning that a man may have a little bit of breast tissue there, or the fat is deposited in the chest area that makes it look as if he has breasts, and it can be significant where it actually hangs down. The unfortunate thing is that losing weight overall may not solve that problem, because if you do have a gland, then the only way to get rid of that gynecomastia is to remove the gland. If it is fat that is there, it's going to be rather difficult for you to do spot reduction outside of, say, liposuction. So usually, once you've hit your goal weight, you may still have some deposits there, or you may have a gland that needs surgical removal. So losing more weight may not necessarily get rid of it completely. It may improve the appearance of the gynecomastia, but you may have to consider a surgical option. How long does it take for the results? I think that's what you want to ask. Well, with the balloon, most of the weight that you're looking at is lost within the first 4 to 6 months. We don't get to final plateaus for bariatric surgery until about 18 months to 2 years. But the majority of all the weight loss will be lost within the first year. Good evening. Unfortunately, I joined the webinar late. Where can I get more info on the balloon procedure? I'm sure MITEC Medical has some information, but you can check out my Instagram page at Dr._Al Dawes. I have some videos that explain all of these procedures, so you can use that as one of your resources to learn about weight loss in general and weight loss procedures.
Doctor, and this presentation is being live through our website, through our page in Facebook. So the person or people could visit the MITEC Medical page on Facebook, and the recording is there. Okay,
great. And a proud product of Dr. Dawes, coming from a BMI of 72.67 to 56. Very proud of myself. Thank you so much. And I'm not finished. Woot woot. All right, let's go. That's great. Proud of you. All right, and Roberta is asking again, after losing the weight, how do you recommend we manage the loose skin that some people normally have? Loose skin, okay, one of the things that we have to appreciate is that not everything you feel underneath your skin is fat. When you are gaining weight, you're increasing the amount of fat in your fat cells. Now, in order for these fat cells not to be sloshing around, your body creates what you call connective tissue. It's like a structural framework like the steel frame for the cement to go in between. It's like the glue that holds the enlarging fat cells together so they don't feel like liquid. When you lose weight, the fat cells empty out, they get smaller, but this glue or connective tissue does not go away. So in weight loss patients, they may still have some areas where they may feel like it's fat and they have a lot of loose skin. And they'll come and say, all right, I need liposuction now. But the reality is that there are not a lot of fat cells there to remove. It is really the glue or connective tissue. The only way you can really get rid of that is surgery to take off that excess skin with the connective tissue that's underneath it. And do you perform anti-reflux procedures with the VSG? One, and do you perform cholecystectomy simultaneously with bariatric surgery? Again, good questions. As I mentioned before, the VSG can lead to worsening reflux. As part of my workup, I always do an endoscopy, and I tend to do them myself so I can see exactly if there is any hiatal hernia. Hiatal hernia refers to the gap between in the muscle, the diaphragm, that separates the chest from the abdomen. Usually it's a small hole that fits snugly around the esophagus that allows the esophagus to pass into the stomach. And there's a valve right there so that when the stomach contracts, the food goes down and it doesn't come back up. If that hole doesn't fit snugly around the lower end of the esophagus where it enters the stomach can actually slide up into the chest, and you don't have a valve that stops the reflux of acid back up into the esophagus. And that's what leads to heartburn. It can lead to chronic coughing, shortness of breath. It can lead to dental cavities, burning and hoarseness at the back of the throat. Any number of issues can be caused by the acid and food coming up. You may even aspirate, meaning that it goes down into your lungs. That can be worsened with a VSG if you don't have a properly functioning valve, because the VSG, as I mentioned, is a procedure where you remove the part of the stomach that expands to accommodate the food. So with food in the stomach or liquid or even acid by itself, it can't expand, and if it's not emptying out, especially at nights when you're sleeping or if you eat and lay down, it can reflux back up into the esophagus and cause problems. So routinely, I always look for a hiatal hernia before I do any surgical procedure, and I always fix them. I always make that hole smaller with a couple of stitches, and then I proceed to do the VSG. Second question, do you perform cholecystectomy simultaneously with bariatric surgeries? If you have gallstones that are symptomatic, meaning that they're bothering you, then I would do the cholecystectomy at that time. Now, gallstones can develop after surgery, or they can worsen after surgery, because as you empty out these fat cells, you're mobilizing the fat for energy. What is in the fat cells becomes available in the bloodstream. So not only is the fatty acids being and triglycerides being used for energy, but the cholesterol that has been sitting in these fat cells for years and years, they come out and they have to be passed out of the body, and they're processed by the liver, passed into the gallbladder, which is a little sac that sits under the liver. And if there's too much, then you can end up with gallstones being formed. And these gallstones can get bigger over time and cause a lot of inflammation, or they may move and block up that channel leading to jaundice, or it may affect the pancreas leading to pancreatitis. Now, to do gallstone surgery sometimes on somebody who is obese, it's a little bit more technically difficult. It adds to the time that you do the surgery. I like to get my patients in and out off the table in less than 2 hours, because you have, with shorter surgeries, less chance of clots in the vein, less respiratory issues, and their overall recovery is a lot easier because they have less anesthetic gases on board. So I usually aim to have my surgeries at about, be finished with my sleeves in a little over an hour. Mini gastric bypasses usually take a little bit longer, maybe about an hour and a half. But I don't like to add additional procedures unless it's a anti-reflux surgery, because it may prolong the surgical procedure. Some persons never get gallstones. Some persons gallstones never bother them. If they do, then that's a much easier procedure to perform later on. But in many instances, persons are able to keep their gallbladders and have their regular life without being bothered by them. But if it is a case where the gallstones are already an issue, then we would just take them out at the time of surgery. Deborah says, I am diabetic, hence my interest in VSG to assist in controlling blood glucose. Do you recommend VSG for control of diabetes? All right, so what the studies have shown is that a gastric bypass is better for curing diabetes. There are many theories, and anytime there are many theories in medicine, it means that there's no one correct theory. One theory is that because the food bypasses the foregut, the part of the stomach, the part of the intestines that is closest to the stomach, and gets to the hindgut, the part that's closest to the colon earlier, it causes changes in the hormones. It may be caused by changes in the bacteria, or it may be changes in the intestines themselves where they are not being exposed to sugar or calories. So they tend to pull the sugar from the blood, leading to better glucose control. Whatever the reason is, I've seen it on numerous occasions where persons may have had bariatric surgery, they're on insulin and they never take another dose after surgery. Their glucose levels are controlled immediately. For some persons, it may take a couple of months. But what I do know is that the remission rate for diabetes, or the improvement rate at worst, is much better for the mini gastric bypass and bypass rather than it is for sleeve. That being said, I do have quite a number of patients who did the sleeve, they lost the weight, their insulin resistance improved, and they got the diabetes under control. But it's usually with the weight loss that accompanies it. With the gastric bypass, most times it's almost immediately before they even leave hospital on day 2. And that was asked already. So no more open questions. So let me try and see if I can get back to the questions that had come in before. All right. One question is, can I lose weight without exercise? And this is a question I get in various forms. One, a lot of people think that because they're not exercising as much as they were before, that is why they are putting on weight. The truth is that exercise is just an extra. You may run a 5K and you only burn 4 with 2 cups of rice, or you may make tea or chicken. So you can easily consume what you burn and you'll be at net zero. How I look at it is that the easiest way to get a caloric deficit by dieting. So you cut out high caloric foods, you count your calories, you get good quality caloric intake in the form of proteins, complex carbs, and healthy fats. And that will go a long way in reduce. So you can move from consuming 3,000 calories per day to 1,800 calories per day. It's going to be much more difficult for you to burn 1,200 calories per day to compensate for that eating habits where you're at 3,000 calories per day. So if you look at it as getting in maybe 300-400, if you're good, 500 to 700 calories per day, that is all extra. But the easiest way to cut your weight while at the same time building muscles is to do exercise. And what you must incorporate is resistance exercises so you preserve your lean muscle mass, which is the greatest contributor to your resting metabolic rate that you can impact. Next question, does it make any sense to try losing belly fat when actually it is a fibroid you have? Does getting rid of fibroid make your abdomen less distended? All right, to answer this question, we need to look at fat. Fat is not all fat is equal. Where your body deposits fat is dependent on your genetics. So some persons will deposit fat underneath the skin, so-called subcutaneous fat. Others will tend to deposit fat inside of the belly, around the organs, pushing out the muscles. That's what we call visceral fat. And again, even with subcutaneous fat, where you deposit it is influenced by genetics. Some people tend to have more of the fat in their midsection. Some tend to have it in their hips and thighs in their rears. So there are a lot of variations, but the key difference, what we need to get a lot of persons to appreciate, is that fat that is underneath the skin is different from fat that is around organs or visceral fat. Visceral fat is most closely associated with insulin resistance. It is also the type of fat that will push out your stomach, making it nice and round. In men, they call it the bear belly. You may not have a lot of fat underneath the skin, but it is this visceral fat that causes your abdomen to be protuberant or pushed out. Now, having fibroids, if you have really large fibroids, it can push out your belly as well. Now, you can have visceral and subcutaneous fat together, but the ratio, we would have to look and see on examination in office what proportion really is inside the abdomen versus underneath the skin, to make that assessment as to whether or not you would have a flatter stomach if you remove your fibroids, or if you were able to burn off your visceral fat. I am 5 months postpartum. My son is not interested in sucking breast because I have not lost any of the weight that I put on during pregnancy. What should be the first I should take in losing this weight? In brackets, exercise, food, supplements, etc. So losing weight after pregnancy, naturally you gain weight when you're pregnant. Some women tend to gain a lot more than others. Yes, feeding does aid in weight loss, but as your hormones come back to normal, your water weight that you had on during pregnancy would have started to go. What you have to do is to try as best as possible to get back in shape, meaning that you have to start exercising. And again, you have to watch your caloric intake overall. You want to be in a caloric deficit. You cannot lose weight without a caloric deficit. It's going to be harder for some persons because of the metabolic and hormonal influences, especially at a BMI of 40, as we had discussed. But ultimately, if you're overweight, you're not at a BMI of 40 or above, then your chance of losing weight by maintaining a caloric deficit is greater. And again, it's not just the total calories, it's the quality, the type of foods that you eat. And Chanel is asking, does endometriosis and dyspepsia contribute to weight gain? So endometriosis usually, it does not contribute to weight gain. Endometriosis is really the presence of the lining of the uterus outside of the uterus. So it may be found in the walls of the uterus, what we call adenomyosis, or it may be found inside of the abdomen, sometimes in the bladder, and the rectum, as far away as the lungs, the brain, and it follows the cycle and sheds every month, causing inflammation. It can cause intense pain and scarring, and the cycle is repeated each month. That doesn't usually affect your weight. It's not hormonal. It is tissue that is responding to the hormonal changes rather than influencing hormones. Dyspepsia generally is a term. It's pretty big. It's what we use to determine stomach upset. So it could be used to explain if you have gastritis, if you have an ulcer, reflux. These are symptoms that are related to irritation of the stomach lining itself. Now, what happens in some person is that what they find is that they get release, or they get some relief when they eat. So they may drink milk, or they may eat and they have food in their stomach, which naturally dilutes the acid. And because of that, there's a classic example of somebody with a gastric ulcer who a duodenal ulcer, who will eat just so that they have less acid in their stomach hitting that ulcer. So they tend to be more of the overweight type. But overall, dyspepsia does not lead to weight gain outside of that specific scenario. All right, I think I have gone through all of the questions. And I think we have made pretty good timing, Carmen.
Yeah, I think you completed or answered all the questions. Thank you so much for this effort, for your time. It was excellent, an excellent presentation that give the details, the options for people to choose what is the best for them. So thank you, doctor, for being here today.
Thanks for having me, and thank you. You have been an amazing audience.